Hi, George. How are you?
How you doing, Dr. Bravo? Today we have another one of those great physicians, Dr. Sue Kressly. Her topic's going to be A Girl Can Dream, value-based and removing process-driven work that is not evidence-based medicine and does not improve care from pediatrics.
Hi, Sue. Welcome back. It's a pleasure to have you. And let's dig deep into some misnomers such as value based care.
Thanks so much for having me, guys. And, this is one of my really top priorities. And I think that's very smart because talking about misnomer value based care, it is used by different stakeholders differently. What's value? Let's start there.
Okay. So I'm going to level set a lot because you're incredibly intelligent, charismatic, and I'm always jealous that you're at the beach. But beyond that, value based conversations started that I can remember with the Biden administration as they were proposing the ACA. And as I understood what they were proposing is mega mergers of as many hospital systems and physicians, integration, the use of EMR for better communication, with the not so openly stated aim of reducing the cost of the expenditure of Medicare in healthcare. Because in Medicare, they're spending $13,000 a year per member. And if it's dual member, meaning Medicare, Medicaid, they're reaching $30,000 a year in spend. And that's not sustainable for the federal government. So they were looking for ways to decrease the amount of money that we spend in chronic disease management. So instead of waiting for my heart condition to get so bad that I'm in heart failure in the ICU, if they can manage me as an outpatient with a scale and a nurse visiting and save that hospital visit, everybody benefits.
So I'm going to push back here
Okay.
because I think that's when the words started being used. But the concept of improving quality and reducing cost has been at the core of insurance businesses forever for a lot of reasons. So I think that the way you talk about it and you frame it as value based payment models may have started at that time, but it's an old story and it's a business principle, right? How do you decrease your overall spend and increase what you're delivering? That's true of whether you own a grocery store or, a hair cuttery or in medicine. So I don't think that it's a new principle. I think it's being applied. And just like anything, when you start to give it labels, people start to make assumptions that they're talking about the same thing and they're not. And absolutely, we spend more money on healthcare in this country with worse outcomes than a lot of other developed nations. And that should give us all pause, and we should all have responsibility in our contributions to that. But they're not printing more money to take care of people, right? Like costs are going up, people paying more for their insurance. Medicare is a problem, and we're seeing it right now because I don't know if you saw the proposed cuts of 3.3% for next year, which is going to be problematic. But the reality is that when they made Medicare a federal government program, they talked about budget neutrality. It's one of the only reasons they could get it passed. But the reality is you can't give more patients because now we have more aging Medicare population. I'm not quite there, but I'm close. And we have advances in medicine. How do you take care of more people doing more stuff with less money? It's ridiculous. You can't. At some point, that's just cost cutting and budget neutrality. Let's talk about that value because many of the payers, the way they define value is quality over cost. Like, I want high quality and I don't want to pay for it. Well, you can't have both. And are we talking about value to the bean counters in the insurance company? Are we talking about value to the patient? Are we talking about value to the healthcare system? In kids, which is the reason we are all struggling, and George, elevated his blood pressure by 20 points in a recent conversation
Oh, yeah.
because there is no way to squeeze more money and juice out of reducing costs in care for kids. The value is because kids are infrastructure. And when you invest in the infrastructure, you build long term value. But these guys who are making these decisions are in their seats for maybe 18 months, and they're told they have 12 to 18 months to reduce spend by 3% across whatever. And that's all they're looking at. That if you're going to look at value in that narrow cost-cutting window, all you're going to do is trim the fat off of everything, and there ain't no fat left in pediatrics.
You're incredibly smart and you know these numbers inside out, but I'm afraid many of on our audience don't know it.
So let's level set. Go.
When I told my dad, who's a lawyer and is 85 years old, that 50% of US children are covered under Medicaid, he said I was nuts.
It's Medicaid or CHIP, but you're correct. Under a governmental program, right at the end of the public health emergency, more than 50% of kids are covered by Medicaid and CHIP. Let that stand for a second, because that equates to the number of children in this country that are living near or around the poverty line.
Right.
Medicare was started because so many seniors were in the poverty sector of the economy.
Right.
Now, half of kids live there. Let that sit with you for a second.
And then I'm going to level set a little bit more because we come from Colombia. And in Colombia, 50% of the population really lives in poverty. Poverty meaning they live in a shack, lucky if they have a toilet, and they cook by burning wood. Okay. No air conditioning, no refrigerator, poverty. Okay. Yeah. He couldn't believe it. He couldn't believe it. He's like, this is the US. How can 50% of the kids live in poverty? How can they qualify? I don't know, Dad, but they do. Okay. Now let's use some of New York numbers. New York spends $2,418 per child that they provide or finance healthcare for in New York State through their Medicaid program. That's less than $200 a month per kid. And the average family in the US spends $220 a month on not counting Netflix, just having TV and internet in their house. So the state of New York, in half their children, thinks that they're worth less than your cable subscription. Swallow that.
Yeah,
There's where you get to value.
Okay.
We
well,
do
but
not
Let me
value children.
let me
We do
level set
not
a little
value
more.
children.
Let me level set a little more because once we talk about the numbers, it's disgusting. Okay. New York Medicaid spends the majority of, New York Medicaid spends $4,600 per adult that can work, that is poor, that enrolls in Medicaid. Twice as much as they do on the kid. The kid can't work. I'm not talking disabled. I'm not talking elderly poor. I'm talking adult that is enrolled in Medicaid in New York. The total spend on physicians, labs, and x-rays in New York State for Medicaid services is $300 million a year out of $3 billion that they spend on Medicaid. So it's nothing compared to what they're spending. And because there's a 2-to-1 ratio, they're not even spending $100 million a year in care for children.
So I have a question.
Yes.
Is that the actual dollars that go to care? Or are we now carving out an administrative crazy overhead on top of that, some of that spend that's not actually going to care?
that's
They,
probably
they don't carve it out on what not healthcare's making off of that. And, that's what they're spending.
the insurance companies, managed care Medicaid, they don't care about pediatrics. I'll give you an example. I had a discussion. I organized for our clinically integrated network. I had people, we got technology to do value-based contracting and dashboards and everything that you need. People, networks, technology to reduce care. Got to the table with some bean counters. And he says, you know what? Do you know what pediatric spend is in the overall healthcare budget? Budget dust, 2%. But you guys, I was with my vice president, Dr. Espinoza, but you guys seem to be like nice guys wanting to do the right thing. I'm going to humor you and give you a value-based contract. They gave it to us, which was fine. Then 2020 came. All of a sudden, things happened. We did whatever we did. We brought in kids during the pandemic. We did have shared savings. So the insurance company made money. The organization made money. The doctors made money. Life was good, right? Fast forward 2021. Repeat the same people, same technology, same everything. Because people started going back because there was a lot of spend with these silly rapid viral panels that cost $1,500 and they pay out that people online. The budget was out of control. We had 2 or 3 kids that had devastating illnesses, some cancers, a liver cancer, a brain tumor. We had 100% quality metrics, but we missed the shared savings, so it's all gone. So we're trying to make a case that pediatrics is different. You have to do it on quality, less on shared savings, because all we could prevent is ER visits and admissions. That's all.
And
we prevent.
hospitalizations. Yeah.
Yeah, they had kids that had $500,000 in medication bills. Then the guy had the nerve to tell me, well, doc, back in 2020, you guys sat down and did nothing and collected all that money. Well, that was not nice of him. I let him have it because we were there every single day. I take COVID very personally. I was on the front line in my office, seeing all these patients that were all the other people closed down, and we saw them and they didn't go to the ER. Yet our organization got zero.
George, I feel you. You're absolutely right in the way
People
you
need to hear the story,
feel.
Herb.
You're absolutely right, but you're barking up the wrong tree.
I
The
know.
problem is the legislatures in Washington, because what some very well-informed people tell me, 50% of the budget for Medicaid comes from the feds, and CMS has a big, big, big hammer that makes you do what they want you to do at the state level with Medicaid, because otherwise you don't get the money.
Yep.
And so that's how it works. So don't tell me that this is a state issue, because as we say in Colombia, you're peeing out of the can. This is a federal and a state issue. But the problem is that
The cultural
New-
issue. It's
that
a cultural and a
Sure.
business issue too.
the
So
New
there's-
York the New York legislature is decided that they're only going to pay $200 per member per month on children on Medicaid that are not disabled and are not in a nursing home.
Right.
And the managed care program says, shoot, they went to the ER. The visit was $1,200. The multiviral panel visit test was $1,200. We can't negotiate that because there's an emergency. We spent the $2,400. We're out of pocket. Where do you want me to come up with the money?
yeah.
Not my
So-
problem.
No, well,
Well, then you have to
it's
advocate to the legislator so there is the money.
it's
Who's
not
going to
our fault,
advocate?
but it's our
Who's gonna
problem.
advocate? Who's going to advocate?
You and me, brother, because there's no one else to do it.
No, wait a second, gentlemen. So first of all, the whole business of medicine has changed enormously over the last 10 to 20 years. And it used to be that people making decisions at the head of insurance companies of what actually happens when you practice medicine. And there were medical directors who worked collaboratively with the bean counters to decide what was the right thing to do for all stakeholders, including patients, to provide care to them. We have absolutely changed that, and the bean counters drive everything. And that doctor or that person you were having a conversation with, George, has no idea what it actually looked like to be in your office during the pandemic,
Oh, yeah.
trying to hold down and keep people safe. There's a couple of things here. The story has to be told, and people have to understand they're not printing more money. We have to look at this differently and totally change the way we approach this in pediatrics. And we have to shift this, and we're going to have to figure out, those of us who want to change the system, what messages resonate with the people we're talking to. We are not good social scientists about messaging, and we have some work to do to figure out what those messages look like. And we'll start looking at long-term investment and what matters. And kids don't matter in this country. The crumbs on the couch are budget dust. There's a lot we can do with a little bit more, and we just need to do it. Now, we're going to have to take from somewhere. They're not going to print more money. So, and we're going to have to sit down and have some hard conversations, and people are going to talk about death panels. And, look, I've told you before, I lost my parents when they were 53 and 59. But you can choose where you spend that money wisely. That's where the value comes in. To me, if you took many people in their, my mother-in-law recently passed. If you said to her, honey, we can put you on dialysis, we can add all these medicines, we can put the in the ICU. You're still going to die in the next 2 weeks and you'll probably die in the hospital. Or we can take that money and keep you comfortable at home and invest that so that 10 families of 3 children each have their investment in themselves to be the best, healthiest from mental and physical and well-being. Can we take that money and use it to them? She would have said, absolutely. But nobody's willing to have those hard conversations. I think the tide is changing as our generation ages. There is more of a movement to get rid of feudal care at the end of life. And we have to work on getting that conversation and reinvesting those dollars where they matter, which is in
A-
investing in the future of the country, which is
Absolutely
kids.
true. And I will tell you personally, it wasn't about the dollars or leaving it to anyone. When COVID started, I saw what was happening with people in the ICU with COVID. I made sure that my directive said, do not intubate me if I get COVID. I've lived a very, I'm going to say privileged, blessed life, a very happy life. I've been extremely fortunate, not at least to be living in this country. And I did not want to be intubated for 6 weeks to then go out in a nursing home at the age of 53. I didn't. I rather go. Now that they're not intubating you, they give you high flow oxygen, and I've been vaccinated and there's medicines. My thinking has changed. It wasn't about the dollars. I just don't think that's how I want to live. But anyhow,
It's-
I've gotten away from the conversation
Go.
here. To your point, the whole, I'm just going to use the ACA as a reference point because it's not too far in the past. The whole idea there is what you're saying is, are there opportunities to provide great care and minimize the expense? Yes, they are. If you, the example you gave, if you're on dialysis and nothing's going to change, maybe it's time to find a transition you. Just like the hematologist will talk about this. If his or her cancer isn't going to get better, what can we do to help them in the last days of their journey? And they don't make apologies for it. That's part of how they see their job. If you have congestive heart failure and we could put a scale in your home and send a nurse aide to make sure you're moving around and you're not gaining 15 pounds, great. Awesome. You know, that because if you land in the hospital, it's a $50,000 spend. If we can spend $1,000 a year doing that and you're better off and you don't land in the hospital, we all
But there's,
win.
we all win. That's the value piece. When we
Yeah.
look at value, it has to be value to everyone. It has
Yes.
to be
Yes.
value to the patient, the family, the health system. It's
In the
that the
country.
hospital's making, well, they're not making enough money, Medicare. They're all dying too because the profit margin. At some point, we have now gotten this profit margin to such a low place that and especially when you're talking about engaging and talking about health equity in this conversation, right? Equity doesn't mean equal. Not everybody needs the same thing to be able to achieve health, optimal health. And if we're going to really work hard at getting some of our vulnerable families involved in preventative care and early diagnosis and treatment, first of all, it takes more money and effort and resources to get them and show them a value, engage them. And then we've just increased our total spend because that population just didn't cost us anything for the last 5 years because they weren't going to the doctor at all. And that's what happened to George. People weren't going to the doctor. Now, all of a sudden, there's this pent up need and demand. And like, in what universe did that payer think that the spend wasn't going up? We have a new problem with new illnesses and deferred care. Hello? That doesn't take rocket science.
Great. I'm going to be very sarcastic. So please, everybody, excuse me. But if you want to save money, quote unquote, in pediatrics, don't pay for well child teams anymore. Run the pediatricians out of town. The pharmacist will give the shots without any screening at all. And because most pharmacies are now huge, like CVS, they can get great value on those immunizations they buy. And the ones that can't go to CVS can go to the health department.
Yep. And then how long do you think it is before society pays the cost of not investing in the children's health and well-being up front?
I just being very
The
sarcastic,
the
right?
the,
But
the
that
mental
will,
health system, we're going to talk about people in the ER with an
that's
untreated
right,
and undiagnosed things,
right,
whether it's
or,
diabetes or chronic
or
disease or asthma. So
yes.
yes,
So that's
if
being
you want to
really
reduce,
that's being really stupid. But
yeah.
you could pad your numbers for United
Oh,
Healthcare
absolutely,
by
absolutely.
doing that.
Yep,
Okay.
yep,
And you would
yep.
get a great parachute, golden parachute, out you go with the use of a private jet and 5 million a year for the rest of your life.
Which is
Now,
one of the reasons when you design value-based payment models for kids, the cost of anything preventative has to be carved out of total cost of care. That is, we should be incentivizing investment. There's a practice friends of mine in Pittsburgh who rocked HPV vaccination rates. So let's
mhm,
talk about the spend down the way for procedures and treatment for cancers. They prevented cancers.
Yes,
Well,
okay.
30
guess
years
what?
from now.
HPV vaccine is a little expensive.
Yes, 30
So,
years from now, nobody cares.
yeah, that's the problem.
Okay.
We are not
So
taking the
we could
long.
also save money. This is going to hurt. I'm probably going to be canceled. But don't do any more mammograms. They're expensive. Let
Yeah,
people
but
get
that's
breast cancer.
yeah, but
I
that's
mean,
but
that's just
that's
the whole wrong thinking about this.
but
Okay.
that's what
Like,
happens when you get bean counters who don't really look at the long view and you're giving them a directive to reduce spend, which
yeah.
is why we have to influence that.
Yes.
Value is not just reducing spend. It is investing in the health of the community. And so the next time, George, somebody says you spend more, the answer would be, what did you do to invest in the health of the community
I
in
like that.
2, 5, and 10 years? Tell me
Okay.
what efforts you put to investing in the long run. Or are you going to be not in your job anymore and it's somebody else's?
So when you're talking to bean counters, you got to talk like a bean counter. Okay. And even though they only care about this quarter because they don't intend to be in the company next quarter, they're going to hop to another job. But let's take HPV. HPV costs, I think, $250 a dose. You need 2 doses, $500. One's with an exam, so now we're up to $600. The other one is just a shot, so you get $20. So what are we, $700 in spending over 6 months?
Over a year. Well, no, one of them is,
Once
yeah.
for this
What?
person,
Yep.
right?
Yep.
Instead,
Max. And most
every
people don't get
year,
paid that much for a well visit.
every year, every year in America, 2,000, no, 4,000 women die from cervical cancer. They spend 300,000 taking care of their cancer. We spend 2.2 billion taking care of cervical cancer. That doesn't count, and I'm not a woman, so I can't tell you if this is true or not, but that doesn't count the discomfort of a vaginal exam, a pap smear, which I've never heard anybody say it's something they look forward. It's like I've never heard a guy say, "Oh, it's time for my prostate exam. I'm so lucky."
But
And
that's only part of the spend, Herb. That's
that
only
doesn't
part of the
count. But
spend.
I'm just telling that doesn't count the women that need colposcopy that was expensive
And have
that ha-
pregnancy losses and
and
have
have
cerclages and have preemies
incompetent cervix
and
and
then
have
we have
preemies.
preemies. Yes.
And I'm not
Yes, yes,
counting
yes.
those 4,000 women that die in their 30s, the cost to their children, their husbands, their mothers, their brothers, the cost of society because this young person is not going to work for 30 years, pay taxes, raise a family, buy a home, use a car, buy groceries at Wegmans. So,
Well then and then
like,
let's add female and male head and neck cancers, which are
Yep.
huge and
yes.
mostly HPV derived. So
Okay.
anyway,
So,
we all agree
no, we
it
don't.
is
We
short-sighted.
agree.
The
We
three
don't.
of us.
Yes.
It is short-sighted when you only look at reduction of cost as your value and let it define value. And I think we need to hold the feet to the fire of the bean counters who keep trying to insist that's the value-based program. No, that is not. That is cost reduction. Call it what it is, and let's define value together from all stakeholders, but with the patient and the family at the center of the conversation. This has to be a social discussion at everybody's Thanksgiving table, not one that happens with the bean counters and George getting frustrated.
Yeah,
So
that's not going to change
I
anything.
ask you, Sue, has any person, organization, institution put this case forward, wrote about this, talked about this with the HPV
Yes.
sector? Who
Yes, you guys are going
other than the Merck companies?
you guys are going to be shocked. There's an AAP, it's not a policy, I think it's a commentary issue, and I think Sue Berman and Sandy Chung are part of that committee. And they talk about the idea of net present value. Net present value is an economic term that doesn't just measure the spend. For example, I buy my house, it's $600,000. That's not the net present value of someone buying a house, because I'm going to need curtains. I'm going to need furniture. I'm going to need this. I'm going to pay property taxes. I am going to do landscaping. I am going to do so many things because I bought that house that helps my little county be well.
You
And
support the economy of your community because you are investing in buying a house.
that's right.
Investing in the kids is the same concept.
Exactly. And
It
there's,
is, yes.
for my Republican friends, which I love you dearly, before you go off the rails, but there's good debt and there's bad debt. Bad debt is when I can't afford the Range Rover and I go borrow money to pay $1,800 a month to lease a Range Rover. I am stupid for doing that. But good debt is when I invest in my business, which has a sevenfold return on my community. Or when I borrow money to buy my house and I pay my mortgage and I don't flip houses, I don't refinance. I buy the house, I enjoy it, I live in it till I can't pay the mortgage. Okay. And the old fashioned way, own it for 30 years, then retire to Sanibel. Right.
Yeah.
But
Yeah.
that is good. That is good debt. That is lifting up everybody. And investing in children, even if we have to borrow the money to do it now, will give us the healthy young workforce that this country needs to maintain its democracy and its constitution. And not doing so now is no longer an option. They're sick. The kids are sick. They are obese. 1 in 5 is depressed. It's a suicide or death by suicide is among the top causes of death in the American young. They are hurting. It is time to
So this
stop.
is no, it's not only time to stop. It's time to start investing in fixing the problem early. If you have any for the listeners who don't know about the Heckman curve, I encourage you to learn about it. The dollar spent in the first 3 years of life pays society for decades beyond that in healthier children, in less spend, but not just in the healthcare sector, in other parts of the economy, in the workforce sector, in the juvenile justice sector, in the educational sector. If the public health emergency didn't tell us anything, it's that we are not investing enough in keeping people healthy. Let's start with the word health, right? Our healthcare system is about putting Band-Aids and treating chronic diseases. It is not about promoting, preventing, and maintaining health and well-being. It is time to really look at that. And who is the expert in the room about investing in prevention, early diagnosis and treatment, well-being, and the long purview? It is pediatricians. We should be, you know how now websites are mobile first? You have
Yeah.
to design everything on your phone so it'll scale to your computer. How about we start designing the healthcare system, the well-being system, child first? Because
Yeah.
if we refocus it on that, we create long-term value and everybody wins. But
That's right.
we gotta figure out how to deliver that message to the stakeholders who make the decisions that make all of this happen.
Without mothers, without teachers, without pediatricians, we don't have a free society. We need those three pillars to grow healthy children that buy into our Constitution and keep us at peace and prosperity. And the time to do that is now,
No,
not
it's
to
yesterday.
now.
It was
But the
actually
next
last week.
the best time to build a tree is or to plant a tree is yesterday. The second best time is today. But here's something that I don't know if you've heard. If you look a couple of decades ago, kids were 33-ish% of the total American population, right? We're now about 23 to 24%. So we are taking up less room, and in the space of the conversations about where to put spend, the population is aging. Look at some of the European countries where all of the kids are leaving and they have no idea they're going to sustain their economy
Yeah.
because there's not enough healthy young people to sustain middle and later in life. We are getting close to that. This is the right opportunity to instill and invest in the infrastructure of children so that we can have a vibrant society and economy for generations to come. The bean counters who are making some of those decisions based on just decreasing this quarter's cost, we have to hold their feet to the fire and hold them accountable when we are in a sicker world in 5 years and it's their fault.
And so I'm just going to go off topic for 2 seconds. In Italy, I keep getting advertisement. Come to this little town in Italy. We'll give you a beautiful house plus $2,000 a month to live for 5 years, but you have to stay in the house for the 5 years and promise to bring your whole family. That's what happens when you don't have young people in a society. That's
Well,
the
and
end
that's the
point.
investment that's where the economic investment in living in a house and all that extra net value that's the net value that Sandy and Suzanne have been talking about as far as the net value of investing in pediatric care.
Correct. I'm gonna move on to another topic that just bugs it gets right under my foot. It's like a little pebble. I can't walk. Okay.
Oh, no.
Oh, yes. Why do
Oh,
we need unfunded mandates that do not improve care, take me away from the exam room? And what are they producing for society?
They're producing their own value. This is a game, and let's just talk about it because everybody's got their special little project, and whether it's DEA, 8 hours of training, and then they want to make us pay for it to begin with, right?
Yeah.
Everybody thinks their edition of their little thing is something that physicians and pediatricians can just do. The problem is we are dying from not even 1,000, now 1,000,000 paper cuts that are stacked up against us. And what they have to understand is it is taking us away from our commitment to serve our patients. Every time they ask you to do an 8-hour CME, that's 8 hours times 3 or 4 kids an hour that are not getting access to care. So the value there of administrative hassles to serve a single narrow goal, is it worth the cost of children not having access to appropriate medical care? And the answer is no.
no.
So how do we figure out goes back to the Kressly question. What problem are they trying to solve? They're trying to solve the problem that they want physicians to stay up on education. And I applaud that because it's really easy to fall behind. But how do we weave that into the daily work where you get, and think to it, guys, the guys in UpToDate got really smart about this, right? Like, I want to learn how to treat Rocky Mountain spotted fever. It's been a long time since I did it. Let me click on something and get contextual knowledge that I apply to patient care, and it doesn't take me out of patient care. We have to figure out how to, there are somebody who's smart technology guys figure this out. figure out in our workflow how we learn while we deliver care. Don't separate the two. They're making us learn here stuff that we'll never see and take away from care. It should be contextual learning. We learn this as adult learners. When you
Yes.
teach adult learners, they're contextual learner while we're doing the job. Get rid of all
Yes.
the rest of the hoops and embed them in the day-to-day work that we already do.
3 points on that. I'll tell everybody, Google it, NB-PAS. Won't say anything more about it. Okay.
Already a member.
Number 2. Did I say that? You're already a member? Good for you. I'd like you even more. Number 2, in the old days when I was a nut, well, I'm still a nut, but I was crazier because I was younger. When I had a paper chart and I saw an interesting case, or something I didn't know really about it, I go down to the medical library, I search it out in some journal, I would photocopy it, and I would put it on the chart. So all of the other doctors in my practice, when they opened that chart, that article was at the very top of it, and it was a review article. And they went like, "Oh, this kid has X. Oh, here's a review article. Oh, wow. How interesting." And then we
Remember
learned,
case presentations when we learned from each other? When we
oh,
sat
yeah.
around and talked about interesting cases and what would you
We
do? And we
as an intern, I did journal club with my attendings in their houses with beer and cheese, okay? And it was a every month event. It's all gone. I will say there's the one kind thing I have to say about ECW. I found out that I can go to Up to Date or I can go to Mayo Clinic
it's
and
tracking your time.
I can do that. No, I can put the hyperlink in there. So I saw a kid in clinic the other day that had been anemic, like hemoglobin 9 for several years, and they're from Afghanistan or Pakistan. And I said, this doesn't make any sense. And they treat him with iron, doesn't really go. I said, maybe he has one of these
He's a genetic something.
anemias or something
Yeah.
like that. Nobody's bothered to do a hemoglobin electrophoresis on him. And so I sent out the whole workup. I looked it up actually from the Academy of Family Practice. And then I hyperlinked the article for the ordinary of the practice on my note. So when she sees that patient in the follow-up, she can click on it and she can say, oh, wow, this is what Herc was thinking. That's
Yep.
the thing. Those are the things we need.
We
They're all
learn
way
from
almost
each
in
other
here.
and we learn while we're
Oh,
doing. And then
yes,
it's
yes.
not memorization of useless stuff and taking a test. It
No,
is reinforcement learning along the way. And
and it,
and let's get rid of the stupid administration that adds no value to care. And let's use that same effort, because it's really the same effort, to strengthen our care, not take away from our care.
yes.
It's just, we
And then
have to do it like daily dusting instead of like go sit somewhere for a day and listen to garbage that you're not absorbing half of because you're also, finishing your charts.
I agree. And so then one more, there's I call it the evil empire. I find it unconscionable, and this is just a legislative fix, that managed care Medicaids in any given state will vary on their rate of reimbursement to pediatricians.
Payment. I'm going to get you on that one.
One
Rate
will
of payment.
rate of payment. One will pay $40 for a physical, while the other one can afford to pay $85 for the physical. So it's not that state's not giving him enough money. United Healthcare just values having margins more than, oh, I said the word. I wasn't supposed to say the word. Than someone else. That needs to be stopped at the legislative end. You cannot contract with the state and not give what the state has decided is a fair reimbursement payment for that CPT code. End of discussion. And if you can't
There
make
has to be a
work,
floor, and it has to be at least Medicare, but probably more, because we have more than one patient when we take care of kids. We take care of a family.
all right. So now I've complained all day, because before you, we had great guest, Dr. Dean, on moral injury, and just phenomenal guest. You got to read that book. And what do we do? How do we solve this?
Well, I think that we have to sit down. We know the problem we're trying to solve. but we're not using the right levers with the right messaging. And so I think that we have to sit down with some social scientists who understand the power of quick words and phrases and framing the conversation from a different viewpoint and so till we can resonate it. And then we have to make this not about somebody else's problem. This is every person, every patient's problem, and understand each of our parts in solving the problem together. We can't do this alone. This can't come from mandates, but it's going to have to come with collaboration, lots of listening, and figuring out the messages that resonate that we can move the needle. Listen, our kids are depending on us. And I know that George had a bad week, but he's going to come out fighting anyway because he knows every day when he sees so much need in the patients that we all serve. Some of our moral, I would say a lot of our moral injury is becoming is because we see the need. And there are others who are saying you can't have the resources to meet him. We're going to make you do this other meaningless stuff again instead. And you can't have enough money, resources to be able to serve the patients and give them what they deserve. And so we go home every day feeling like we failed. And that's not us. That doesn't take more yoga and more walks on the beach in Sanibel. That takes healthcare system redesign. And it's time to relook at the whole thing.
All right. So I'm going to do lightning round with you. One, should we be investing more than $200 a month in our children?
Yes.
We need a new guide, right? A net value ruler
Yep.
for when we're spending, not just, oh, the physical cost of $100.
It's not spend, it's fund, it's net value of infrastructure investment. We have to change
Okay.
that conversation.
Every pediatrician that has access to their, in New York, it's called a delegate. Here we have a legislature and a Senate that has the opportunity to talk right to their representative at the state level, and their senators should do it today.
But we now give me a week. We need to give them the right talking points in a language that's going to resonate so it just doesn't end up in the circular file. Soon.
Okay.
Be ready.
All right.
Know who your people are. Come send me your talking points. Let's figure out which resonates the best and what has the most impact, and then let's talk. But figure out who your people are.
Okay. We need to ask our mothers to write to their representatives and tell them what difference, and I'm going to be very self-centered, I did for them. And I'm going to tell you a short story. Yesterday, when you texted me, I was at a fundraiser for juvenile diabetes. I was there, and remember, I've been a hospitalist, an ER doc, an urgent care doc, and I never did the journey that you or George did, where I put up a practice and was that practice for 30 years. The mother of the patient that brought this little kid, since he was in diapers as a newborn, to the urgent care, called me one day and said, I won't say his name on the air, but Johnny, he's peeing a lot and losing weight. I need to see you today. I said, come in. She came in, the glucometer wouldn't read because it was so high. And she said to me, it's diabetes, isn't it? I said, yes, you're right, it is. Let me call the endocrinologist at the Children's Hospital and see how we can get you admitted. That was more than 10 years ago. He's now a thriving adolescent doing the call circuit as he applies for colleges. I have taken care of him, his brother, his mother, his grandfather, and his uncle over pictures. When she brought him to the urgent care, that night I cried with my bourbon because I knew how long that journey was going to be for that family. I am so blessed that they invite me to these things. And when she introduces me as my friend Herb. And right away, her girlfriends say, that's not your friend. That's Dr. Bravo. We all know because you don't do anything without talking to her. Anything that's medical and anyone in your family, he has to figure out whether they're telling you the right thing or the wrong thing. And that you cannot buy with money.
Yeah. let me just say, it is that human relationship and the humanity
Yeah.
that you cannot, the bean counters, they discount that. Ask them, George, how many lives did you save this month? How many lives did you save this month? We all have those stories, and that's what fills our heart. And I'm going to leave you with this last thing. Every day we wake up and understand why we went into this godforsaken, beautiful profession called pediatrics. It's because our patients matter, their families matter, and every day they give us hope of a better world. So let's partner with our kids and families that we're privileged to serve and dare to hope that we can make a difference and make a better world. We can do it, but we have to do it together.
That's right. Thank you, Sue.
Thank you. Always a pleasure, guys. Keep the
Likewise.
fight. Bye.
Likewise.